Hello class, this is lecture 11 for the co-occurring disorders course with Dr. Greg. So for what we're covering for week 11, this final week, we have a few readings. Neither are from a textbook, we're all done with textbooks, so we're just going to be reading Farid et al. 2013, Cusack et al. 2016, and then we'll also have you view the last week tonight video. For the lecture topics, though, we're going to be talking about opioids in general, kind of briefly talking about the Farid and Cusack articles, talk a little bit about Alcoholics Anonymous, and then I'll give a fairly detailed review of the various medications that you may encounter, especially when dealing or helping treat individuals with co-occurring disorders. So let's go ahead and jump into it. Before I go into the two article readings, I wanted to give a very brief review on how to evaluate treatment outcomes in research. So I think one of the most important things in being able to decide on appropriate treatments to give people is to really have an understanding of, well, how research works and how to really get your own feel for the results of research so that you can decide for yourself what type of treatment modalities will be of most benefit for you later on when you do choose to get training in particular approaches. So um, we have three different concepts here I want to review. One is efficacy, then another is effectiveness, and then effect size. So the first two are just particular ways that different treatment methods are researched. Efficacy research involves researching a particular treatment approach under highly controlled circumstances, um, where the researchers will use their own labs, perhaps, or their own clinic. They will specially train everybody individually in the manualized version of their treatment. They will control as many variables as they can. Usually, they'll, search for a very specific sample of individuals that the treatment is meant for. And the reason they do this is because this provides very good internal validity, which basically means that when they do this kind of controlled study, they're really able to determine what particular variables of this treatment approach are more useful than others. So this can be a very important treatment method for you in order to decide what parts of a treatment actually work best. Now, effectiveness studies, in contrast, are studies that are done by other people who did not create the original treatment modality. They will take the manualized version of this treatment approach and then conduct their own research in a more naturalistic clinic where they may get a much wider variety of clients. Now, of course, there's not going to be as good of internal validity here because it's not often guaranteed that all the clinicians are using the treatment exactly as intended, nor are they always using it on the types of clients who it was always intended to be used on either. But an effectiveness study gives a much more realistic view of how a treatment approach is going to work in real life, which can also be very useful. It's just important to keep these two different types of research in mind so that you're getting a good idea of what they were actually examining and what it means to you when it comes to picking a certain research approach. The last concept here is effect size. Oftentimes it's done in Cohen's d, although now there's a variety of other statistical measures out there that also measure effect size. But the very basic concept of any effect size number is that all it's measuring is the magnitude of the difference between two groups. One is typically the experimental group, and then the other is going to be some sort of control group. And then you divide that difference by the pooled standard deviation. All that really means is that you're taking the difference. So let's say we're measuring how much somebody's depression has reduced as an effect or as an outcome of a certain study, right? So we're saying someone's depression went from 10 to 3, right? So one study had a 7-point reduction, where the other study showed a reduction from 10 to 6. So that'd be a 4-point reduction, right? So we're looking at the difference between how much of a change happened between these two treatment methods. And then you're dividing that by the pooled standard deviation, which is the standardized or the aggregated standard deviation between these two studies. Doing so gives us a very representative um, number, and it's a universal number in which for us to make general comparisons between studies. Now, what's so important about effect size is keeping in mind that it is a comparative number. So it also really depends a whole lot on what you are comparing. See, I have some broad ranges. So these are the types of numbers you're going to see from a standard effect size. Effect sizes can go above 1.0 as well. So anything above that is considered a very large effect size. 1.1 to 0.3 being small, and you can see here. But keeping in mind also that the general degree to which or the severity of an effect size also matters greatly between what two treatments you're comparing. If we were to take just like a placebo or a treatment as usual, well, that's going to be different between, that'd be much more different than comparing your treatment design to another proven effective treatment design. For instance, if I was going to compare mindfulness-based cognitive behavior therapy to somebody who's just on a wait list, well, we'd want to see a very large effect size there. However, if I was going to compare mindfulness-based cognitive behavior therapy to REBT, rational emotive, which is another form of cognitive behavior therapy that's already been proved to be very useful, well, then even a very small effect size would be very important, especially if it's in favor of mindfulness-based cognitive behavior therapy, because we're comparing it to something else that's already proven to be good. Anything above that is going to be rather impressive still. So that's an important thing to keep in mind with effect sizes whenever you're reading studies, as well as the general structure of the research that you're looking into. Okay, so moving on from that, we're going to look into Fried et al. For the 2013 article. Oh, look at that. I forgot to put a little period there. So I want to make sure that I'm always showing proper APA citations. So let's make sure we have that in there. All right, so the basis of the Fried et al. Was to give us kind of a literature review, especially about how PTSD symptoms and opioid medications all kind of come together to create a very challenging experience, especially for people with PTSD and their vulnerability to becoming addicted to painkillers. Basically, Fried et al. Looked at how PTSD symptoms have subjective pain involved in the symptoms that clients report, which is considered an overall increased pain sensitivity. Of course, adding this all up, this means that opioids may serve to reduce some of these PTSD symptoms because they're reducing this perceived pain sensitivity people develop as a result of experiencing PTSD. It's kind of the way the nervous system becomes chronically wired, becomes much more sensitive to anything on an emotional level, which can take on a physical manifestation of pain. Hence why opioids can be a very tempting medication to continue to use. Withdrawals from opioids, and this is another thing kind of just defending this link, which is they found that the withdrawals from opioids activate the same area of the brain associated with PTSD in the locus coeruleus. So there's a very clear link there, as we can see, that the withdrawal symptoms, which is what happens when someone stops using a medication, activates the same areas that PTSD do for somebody. So what does this mean for a client with PTSD? It means that if they ever do get prescribed a opioid medication, like for a dentist office or something like that, they could end up feeling triggered by their PTSD when they stop using this medication and have no idea why. It's because they're experiencing maybe just mild withdrawal symptoms, but that might be enough to scare them into continuing to use their medication. So we see a really high risk there. So what the Fried article, oh, look at that, I forgot the period again. Very silly of me. I probably did that a few times, so I might have to just give up on that if there's any more of those in there. Oh man, look at that. And then I even put it in the wrong spot. I'm just failing all over today. Let me just fix that there. All right, gotta make sure I'm showing this the right way. Anyway, so their proposed solution here is the medication buprenorphine, which we talked about a little bit later in the course. They think it would be a very good substitute, especially for people with PTSD, because theoretically buprenorphine doesn't cause euphoria. That's because buprenorphine is considered a partial agonist of opioid receptors, which means it's supposed to be less intense than something like heroin or other medications that are prescribed to individuals like Vicodin, for instance. This should be less potent than even Vicodin. Overall, it helps reduce the symptoms of withdrawals, doesn't create any sort of overdose risk because there's also a blocker put into buprenorphine, or Suboxone is what it's called when you add the blocker to it. It can overall reduce opioid use, although it doesn't treat the PTSD symptoms directly. They're basically just proposing that buprenorphine can be a good replacement for someone with severe PTSD symptoms who may be experiencing possible addiction to opioids. Uh, They also mentioned that Seeking Safety is a widely used and integrated treatment program that can also help develop proper coping skills so that the individuals can cope with both the PTSD and possible substance use difficulties. Moving on from that, kind of segue over into the Cusack et al. Article from 2006. Wait, that's not true. That's 2016. Look at this. All my titles are wrong. Let's go back and, yes, 2016. Well, I'm just having fun going through this and fixing all these slide titles. Let's make sure I don't do that again. Yeah, looks like we're good for the rest of these. Caught another one though. Yeah, so this is the Cusack et al. 2016 article. This was a meta-analysis of a variety of different PTSD treatments. They examined exposure-based, skill-based, and other therapeutic approaches, and then they rated them. This is the important part. They rated them according to their overall strength of evidence. So this doesn't necessarily mean they were rating them according to their overall effectiveness. This was not like using the effect size like we talked about before. In this, they're just looking at the overall consistency and strength of the evidence across all the research. It's not saying whether or not these treatment methods are effective or not. So it's more just about the consistency of the existing literature that they were looking at, not necessarily the overall effect sizes of these different studies. So first off, one area they looked at were cognitive behavior therapies, which had an overall moderate strength of evidence. This includes cognitive therapy, cognitive processing therapy, which had insufficient evidence in some areas of outcomes, and then also cognitive restructuring. So those are just some broad areas that they talked about in Cusack. And they looked at coping skills therapy, which had insufficient strength of evidence, though some could be efficacious, such as stress inoculation therapy, which you read a little bit about in the article. There's also some exposure-based therapies, and those ones attain very high strength of evidence, especially things like prolonged exposure, which can be imagined in a normal therapy setting, or it can be an in vivo exposure where they're actually out in the real world, exposing themselves to things that trigger or remind them of their traumas. A little bit more, there's a couple of mixed therapies such as eye movement desensitization and reprocessing, EMDR, which had a overall low strength of evidence for the symptom symptom reduction areas, but they did have a high moderate strength of evidence overall in terms of whether or not somebody still had PTSD afterwards. So a little bit of inconsistency in the research when it comes to EMDR, although there is some evidence that it can be helpful. There was also a narrative exposure, which had a moderate strength of evidence. And then there are a couple uncovered therapies that they were thinking about looking more into, such as hypnosis, interpersonal therapy, and psychodynamic, though there just wasn't enough research out there to really say for those ones. So they really had no strength of evidence so far. There are a couple other therapies that had insufficient evidence overall. Brief eclectic psychotherapy was low. Seeking Safety had more effective than just doing substance use therapy alone. So although there was insufficient evidence for Seeking Safety when this study was done, it was starting to show some fairly promising results, especially for people who had PTSD as well, and especially in helping more so than just regular substance use treatment. COPE had insufficient strength of evidence, and the imaginary rehearsal therapy had insufficient strength of evidence. So they got a lot more work they think that needs to be done in some particular areas there with these studies. All right, so I'll talk about the 12-step meetings real briefly, and then I'll cut this video. So obviously, 12-step meetings are referring primarily to Alcoholics Anonymous, though it can also refer to a very wide variety of anonymous groups such as Narcotics Anonymous, Gambling Disorder Anonymous, Marijuana Anonymous. There's a lot of different variety of different groups out there. Although I believe in the Kalamazoo area we mostly have AA and NA groups, but you will find some of these other groups out there too. The only global membership rule of any 12-step group is the interest in sobriety or recovery, depending on whatever it is the group is about. Serenity prayer can be particularly compatible with mindful awareness because it's all about accepting what you can't change and changing what you can, just one day at a time, being as constructive as you can. Can be used as a CBT problem-solving tool in that way. Some of the criticism of 12-step groups is that there is a focus on God. However, a lot of the 12-step meetings do have agnostic groups too. And there is also a chapter specifically dedicated to agnostics in the big book, or the book that people read as part of doing the 12 steps. Has a whole section on how this can be a good group for agnostic individuals as well. The groups have individualized cultures based on members, which can be good or bad. It really depends on the opinions and the personalities of each individual group. That can really make or break a 12-step meeting. And so it's very good for people to shop around, take a good look at a variety of different groups before they really settle on where they want their home group to be. And then from there, they can get a decent sponsor and overall find a decent experience throughout 12-step meetings. All right, so we're going to move on to medication classes for the last final bit of this lecture, and then we'll be all done. So I'm going to start that in the next lecture section.